Well, thanks, everybody. We appreciate you joining. We appreciate the opportunity to share this great information with you all and our partnership with Texas MGMA and frankly, a number of other chapters around the country that have tapped into this. And so I'll go ahead and do a couple quick introductions and then turn things over to Dan. Dan, you want to go to the next slide? So my name's Carl Bertrams. I'm the VP of Sales Business Development for Provence Health. We're headquartered out of Indianapolis, Indiana. Dan Tashnik is our founder and CEO. Dan, in previous life, was a healthcare attorney in California. So when he started this company 5 years or so ago, he came at it from a background of compliance and working very closely in consulting and sometimes defense of practices and hospitals when it came to Medicare rules and regulations. So Dan's a pretty well-known subject matter expert in this field, and I'm going to turn it over to him because he's got all the most important information for you.
So thank you everyone for joining us today. We are going to be going over quite a bit. Before I do that, I'm an attorney, but I am. This is sort of the sort of required disclaimer, right? This is one. I'm an attorney, but not your attorney. Not legal advice. The big thing to take away here, though, above sort of just the general disclaimer, is this stuff that we're talking about, telehealth in general and telemedicine. It's changing, and it's changing quickly. Which hopefully by the end of this talk, you'll have sort of an idea of anyway. But definitely before you start billing anything, it's worth always talking to a billing professional and who's sort of up to date and kept up with these things. So anyway, disclaimer over. But before we sort of jumped in, worth speaking through. What are we going over today? So when we say telehealth, sort of in the general vernacular, right, we mean a lot of different things. So the first thing that most people think of is telemedicine, right? So audio-visual or audio telemedicine, doctor in one place, patient in another place, having a visit over, either the phone or video chat. So obviously we're going to be talking about that. That's a big part of this. And I'll go over the history a little bit as to what that looks like. So that's telemedicine. CMS has a tendency to sort of conflate telemedicine and telehealth. But for our purposes, we'll talk about that as telemedicine, right? Audiovisual telemedicine. Then we have remote care more generally, right? So telehealth, that includes care management, right? Audio only calls for care management, remote monitoring, a couple of new services like advanced primary care management, which I'll talk about briefly as well. And we'll sort of do more of a broad view of telehealth coverage under Medicare primarily, but also generally. Medicare is the easiest to sort of put in a box and label, but we'll talk a little bit about private payers and Medicaid and things like that too. And then finally, just how this is changing and the strategies that are involved in keeping, one, up to date with what's going on, and then two, expanding out for the opportunities of telehealth. It's, especially during COVID, it was a lot of groups were forced into doing this, right? Into sort of providing this. And you have different levels of what would have been natural organic adoption versus like pandemic, right? All my patients are vectors adoption. So we'll talk a little bit about sort of the future, how we see this growing, and how you can really benefit from either embracing it or even if you're embracing it sort of piecemeal and being more specific in how you want to embrace it, what areas there are that are growing and how they look. And then at the end of it, Q&A. First, to jump into the telemedicine coverage. Now, I was, before I started my current company, Provence, I practiced mostly Medicare regulatory consulting, some audit defense, things like that. But until very recently, really, I started my company 5 years ago, and until then, it was a pretty easy timeline, which was the Social Security Act of a long time ago, right, says explicitly Medicare is not allowed to cover telemedicine. They call it telehealth, but really they meant telemedicine, right? The limit was basically to rural areas with like documented provider shortages. It was extremely restrictive as far as where the patient has to be, where the doctor has to be. Home telehealth, right? Having the patient at home didn't count. And for most of my career as an attorney prior to starting the company, and even most of the, the first 2 years of the company, right? So until around 2019, 2019, the idea here was Medicare saying, we can't regulate coverage because it says in the Social Security Act that there's no coverage. So it would take an act of Congress for us to be able to allow telemedicine. There were at least 5, I think more bills since 2010 to until 2019, attempting to open that up and allow for some coverage. But none of them made it through. So before COVID, and you sort of have to think of this in two, sort of like a before COVID period and after COVID period. Before COVID, CMS did one thing in about 2017, which was they said, okay, well, we're going to define if the Social Security Act says we can't do this, we're going to define telehealth specifically as audio video visits, and we're going to have these other technology-based services and care management services that when me and you or layman talks about telehealth, they think of these things as being part of telehealth. CMS said, well, they're not. They're not part of telehealth because we're going to regulate that you're allowed to, we're going to pay for it, right? So they sort of, I don't want to say skirted, but they kind of skirted, right? Their previous thing, which was Social Security Act says we can't do it, we can't do it. Instead, they split out video visits and audio visits, right? Doctor or provider, any provider, right? Provider, patient talking in real time, interact communication in real time with remote patient monitoring. Store and forward, like, here's a picture of my mole, right? And you looking over it. Virtual check-ins that are these very short 10, 15 minute or less check-ins that you can do. And they said, all of these things aren't telehealth, we'll cover them. That's what happened. So there was that split, and that happened until COVID. And that was split, I think I said 2018. It was earlier than 2018. It was early 2010s that they made that split. 2019, COVID. 2020, COVID. At that point, we've been looking for congressional action for a long time. And I won't go too deep into this. This is the only slide on history, I promise. COVID, we decided to have, the Congress passed, the sort of emergency legislation and gave Medicare the authority to waive the statutory restrictions during the national emergency. So CMS opened this up. And I'm sure a lot of you were practicing during this time or practice managing during this time. And basically, audio visual telehealth, and then they opened up just phone call, audio only telehealth. They said, don't worry about where the distant site is or where the patient is, basically during the emergency. So then you might also remember after the emergency technically had ended, or excuse me, had generally ended, the public health emergency kept being sort of kicked the can forward. And part of that was because CMS and HHS knew that once the emergency was gone, it should go back to Congress, right, as to when they can do these things. And all the patients who have been benefiting from telehealth and telemedicine particularly, right, those patients will want to continue getting telemedicine on Medicare, but, they didn't necessarily know that Congress would do anything. So with the expiration of the national emergency, Congress has to either make those waivers permanent, right? Amend the Social Security Act or have a new law, or temporary extensions. And as you might know, there have been multiple temporary extensions since 2021. And towards the end of each extension, there's a panic where we say, oh no, all of our extensions are going to, expire. And then last minute, especially this last time in March, last minute, Congress passes a law. In this case, it was the spending bill in March of 2025 and extends the waivers a little bit longer. The waivers, and there's a bit of, you have to think of this sort of almost in two tranches, really three tranches. The first tranche is that stuff that was split off, telehealth, like remote patient monitoring, chronic care management, virtual visits. Those are covered regulatorily. So those are always covered. There's a lot of people there's some confusion there. Whereas when they hear telehealth waiver, they think, oh, well, remote monitoring and getting a phone call from a clinical staff for care management, that's not covered. That is set law, set regulation covered. And then you have to think of, okay, telemedicine, calling the patient with the doctor, that's what's being extended. And then there's different aspects to that waiver, right? So within that waiver, there's been some things that Medicare has been able to say, these things are permanent now. This is a part of the waiver that we're going to just continue moving forward with. And then there's other things that they can't. The big thing that they can't, or they say they can't, is what's called distant site and originating site requirements, which basically, under the Social Security Administration Act, are extremely restrictive. So that's what stops most telemedicine. But they've been able to expand things out a little bit with permanent regulatory action. So it's not just a yes or no question anymore. It's sort of, are you mental health or behavioral, right, services? In that case, we've extended that a little bit more, or we've made some of that permanent, right? And other parts not permanent. So I'll go through that, but just know that it's not really like a one size fits all thing. And it is as complicated as a Medicare sort of morass as you might expect. That said, at the end of this, we'll sort of go through through all of it and say, like, here's what's doable, here's till when, and here's why. A takeaway, if you don't listen to a thing else I say in this sort of this meeting, is until September 2025, the current extension basically makes the type of telemedicine that you have been doing since COVID okay. It is a pretty broad extension for telemedicine, right? Within that, just to be more specific, this includes no restrictions on where the patient is, where the provider is, other than it being within. I mean, really, no geographic restrictions, at least, right? All eligible Medicare providers can do telehealth services with no extra, credentialing or anything like that. This includes for FQHCs and RHCs as well as more standard traditional practices. And for behavioral health, you don't even require. So behavioral health is one of those areas where there was some permanent fixtures that they allowed, but they even basically said, "Don't worry, the same way you were doing it during COVID, you can keep doing it." One area that was interesting is that when we say telemedicine, there's really two types, right? There's video and audio, and then there's audio. And Medicare was very clear that they always wanted audio whenever possible. Originally, it was required that you had to have audio. Had to have video. I apologize. Had to have video with every encounter. They have since let that go a little bit, which is a good segue into this is the waiver extension, right, in the March 2025 bill. Well, then there's also telemedicine expansion that happened during the final rule. So think of the bill as sort of general expansion under sort of the sort of the waivers within COVID-19, right, during the emergency as far as audio and visual, but it's temporary till September unless they make it permanent. The stuff that is through the final rule is permanent. It's going to keep going unless they said specifically that it'll stop after a certain point. The first thing to take away from that is they're allowing coverage of two-way real-time audio only. So the takeaway here is not video, audio only for specific parts, specific kinds of telemedicine within this. The big one is if the patient's not so the big takeaway, not big takeaway, sort of quick context. During COVID, they allowed audio only telemedicine. Then they sort of started taking it back, and they got a huge outcry that a lot of folks on Medicare, especially older, maybe not as tech savvy, don't have super great use of video technology. So you had these situations where you would have audio with the patient, and you'd be sitting there and they were trying to get their video working, and you couldn't get paid unless they did, which doesn't sound fun, right? So the idea is that they expanded it out a lot. They said, listen, we want, whenever possible, for you to use video communication too. But if the patient's not capable or doesn't consent to it, you can use audio. It's interesting because the question then is like, well, how much do you have to, if the patient says I don't consent, fair, but what does not capable mean, things like that. I think the thing to keep in mind and the thing to make sure that you do in your practice is just document. Patient is not, currently capable of doing video, fine, probably enough, right, for this. But I wouldn't just do phone calls left and right when this goes into place without any documentation of whether or not video is possible. So that's one aspect. The other aspect is, so the distant and originating site were baked into the Social Security Act. Distant site, excuse me, the originating site is where the Medicare beneficiary, the patient, is. The distant site is the place where the provider who's doing the visit is. So CMS, through December 2025, allowed that patients, right? So if the practitioner is at their currently enrolled practice location or not, let's say the physician's at home, they can still use their practice location for billing and claims when providing services from homes or from other areas. So basically, you don't need to update your enrollment application to like report your home address or where your telehealth site is. You can continue to use the address of your site. They also specified, so they always had this list, but it never mattered much because the telemedicine rules and telehealth rules were so restrictive that not much was being done anyway. But they always had this list of the services that could be done under telehealth if those restrictions were met. When it expanded out, this list is way more important because a lot of these services now are being done via telemedicine or telehealth. So right now they expanded that list. There's 280 services, and they split them by either permanent, which means we foresee paying for this via telehealth forever, or provisional, which means we're gonna pay for this, but also we need more clinical evidence, right, that there's benefits of these services. The vast majority of these things are E&M services, right, which are part of those payable under telehealth. So if you're looking to do things that are outside of that, it's important to look at this list and see. But if you're doing just normal office visits in a telehealth scenario, sort of in that modality, those are generally covered. Same thing with annual wellness visits, most preventative services, things like that. But otherwise, they now have a list where they can expand or subtract the things that can be done via telehealth. A quick sort of note here is that during the health emergency, they had CPT codes that were specifically for telephone based. So they sort of had the subset 99441 through 443, where if you did a phone call, it was under those codes versus the normal E&M codes. That's done away with. So if you're still doing that, I mean, given that it's a few months in, you probably got the dials if you're still doing this. But as of January, right, of this year, use the normal office-based codes, but use a place of service, right, with the patients that shows the patient's location, whether it was telehealth or something like, or not. This is sort of separate from those split offs that I first talked about, right, which they call technology-based services, which are not considered telehealth. Virtual check-ins, remote patient monitoring, care management. Other than that, these are the 280 current services that are payable when furnished via telehealth. So the virtual health, so there's one sort of, this virtual direct supervision changes are kind of peripheral to telehealth, but they're still important to talk through because it's peripherally related at least, right? So supervision requirements are whether or not the doctor and clinical staff that might be furnishing a service. So let's say I'm a doctor and I have a nurse who does annual wellness visits. Annual wellness visit is a direct supervision service. So it can be furnished primarily or mostly by a clinical staff, member of my clinical staff, but I need to be within direct supervision, which historically has meant in the same building, right? Basically that there's like, you can immediately access the provider if needed during the clinical staff furnishing the service. CMS extended, the waiver during COVID was, well, we'll just say that as long as the provider is accessible via basically phone call and video, that it doesn't matter if they're in the same building anymore. They can still do direct supervision for these services as long as they're reachable by the clinical staff. So that was during COVID, and they've kept extending that waiver going forward. So right now, they've extended it through 2025. And they said, well, past 2025, we're gonna split the services and say when virtual direct supervision is allowed. This is particularly important for when, let's say you have a nurse who might be I don't know, at home and doing annual wellness visits or preventative services at home, or in the office when the doctor is, I don't know, doing hospital rounds or just not in the building, right? Should they still be allowed to? Until the end of 2025, they are. And then after that, they're splitting the services that you can do this in. The services that they first listed out are very limited to the point where it's not super exciting. It's basically it's not a continuation, right, of allowing virtual direct supervision. But there's a lot of pushback on this. So the question is, are they going to expand that list? Are they going to allow direct supervision? Or again, they have to pass a overarching legislative rule on by September, or else all the telehealth collapses to almost nothing. So this is one of those things, and one of the reasons we brought it up. This is one of the waivers that we expect to, as a possibility, to be included in that bill. If I won't comment on whether or not our current Congress is, super on the ball with everything. That said, they're expected to pass something. This is one of the things that would most likely be mentioned, or at least has a good chance of being mentioned in that something. Because at the end of the day, it doesn't matter what CMS says. If there's legislation saying you cover this thing, CMS covers that thing, right? This is one of those things that are getting quite a bit of lobbying and pushback to expand more broadly. There's one other service. Now, this is separate from the waiver. This is one of those services that before COVID, Medicare basically said, these aren't telehealth. So you don't have to worry about anything changing really as far as like month to month when it comes to advanced primary care management. But it was announced and rolled out this year, and it involves telehealth and it doesn't technically involve telehealth, but for all reasonable interpretations of the word, it does. So it's worth talking through because it's actually it's an exciting new service generally that primary care or specialty care who provides primary care can do. And it also sort of shows the future of how Medicare is looking at these services, which you might love, you might hate, depending on sort of where you stand with value-based care and sort of population health payments and things like that. So I'm guessing, given you guys are on this webinar, that a majority of you have some sort of fee-for-service aspect of your patient population. Maybe you're part of an ACO or you have some value-based care contracts, but there's some fee-for-service. As you also probably know, Medicare has been trying very hard to move people away from fee-for-service towards value-based care, probably as long as I've been around, 10, 15 years at least. Longer, to be honest, but at least that. So they've had multiple different sort of forays into this. This latest one, and it's actually they're going almost all carrot and no stick on this, is called APCM. APCM basically allows you to bill for every one of your Medicare patients, fee-for-service Medicare patients, for providing them the option of having what's called basically technology-based and care management services. You don't have to give them those things every month, but instead you can bill every month as long as you are a practice that has them available for your patients. There's a few other things because you also have to you have to do some population health reporting and things like that. But basically, everything else is sort of secondary to just that. You have to have two things. You have to have some sort of care management that's happening, and you have to have the ability of having like virtual check-ins, messaging through a patient app, telehealth, right? And as long as you provide those, or at least have them available, you can bill for each one of your patients every month for advanced primary care management as long as they're consented into that program. Medicare is seeing this as a way to introduce population-based concepts into fee-for-service providers. And they're not super subtle about saying pretty explicitly that we're trying to incorporate those two models in. We're willing to pay you for each one of your patients as long as you have these things available, whether or not the patient utilizes those things any given month, because we see the value in having those things available in a fee-for-service world. important to take away, some of you might be familiar with chronic care management, which is similar to this, except for it requires 20 minutes of time each month. This is no time required. You have to be able to have the time, so you have to offer it, but you don't have to do it. So let's say a nurse talks to the patient for 5 minutes one month, 80 minutes another month, and 2 minutes the next month, or 0 minutes the next month. They're all billable each month for this, as long as the other requirements are met. So the reason that this isn't, or one of the reasons that this isn't considered telemedicine, it's telehealth generally, but it's not under Medicare, is because it can be delivered by clinical staff for almost all of it, right? So this is basically means that, and a lot of practices are already doing this, right? How often do patients call in and talk to your clinical staff about their medication or their blood pressure or needing refills or any of the sort of non-provider based E&M visit care can be pushed into these care management programs? And usually that means that you have to count up your time. If APCM means you don't. There's 3 codes for APCM. They're split out based on, it is a poor man's risk stratification is really what it is. I mean, the sort of the rhyming it has with population health schemes, not schemes, I don't mean that pejoratively, but like payment, schemas is pretty close. So if the patient has 1 chronic condition or fewer, $15 a month per that patient without having to, have any specific time done. 2 or more chronic conditions, which is the majority of Medicare patients, 50 per month billed, ongoing. And then if they're a qualified Medicare beneficiary, which means that they're joint enrolled Medicare, Medicaid, and hit specific income requirements, 110 per month. Medicare is explicit that it expects to some extent, not to some extent, that it is okay to basically bill, as long as they're consented into this program and have access to these different things, your entire Medicare patient population on this. Which means that instead of doing just provider patient telemedicine visits, right, where you're billing under E&M and they're very similar to they're basically a normal office visit done over the phone or video chat, right? This allows you to have more month-to-month longitudinal service where you might be managing a patient with clinical staff, not necessarily the provider, but when the provider would need it, and being able to bill for it on a month-to-month basis. So that when they call and you don't have to funnel everything into 15, 20-minute visits with the provider. You can bill for actual more ongoing telehealth as needed for the patient. This is an interesting, I would not have guessed that this would be the way that Medicare does this service when I first started practicing. It is definitely, just talking through it, you could tell that there's a lot of, it is more loosely defined than most of their services, right? But it shows how much Medicare cares about telehealth, especially between visit telehealth, that they're willing to pay for what amounts to a relatively, you should not abuse it, because the next audits are talking, the next slides are talking about compliance and audits. But this is pretty abusable if you think about it, right? You shouldn't, and maybe it's not abusable any more than anything else, but it's hard to really patrol, I should say. So they really care, because they know that. They understand that if you're billing for every single patient because you're telling everybody that you have these things available, that they're going to get a lot of people just billing for patients. And they care enough about it that they're willing to spend the money for the good faith programs that, let you do between visit care under APCM. Anyway, maybe too much of you're going down that road, but definitely an interesting service. It speaks highly to how Medicare is seeing how this works going forward. It would be interesting to see if Congress expands or makes permanent some of the telemedicine, the telemedicine visit side of things, which to be honest, the expectation is, unless there's the expectation at this point is bipartisan support. Everyone wants to extend the tele waivers, right, for telemedicine visits. That said, it's going to be some, they barely passed the bill in time this last time because of other things that were within the bill that took precedence, right, or at least took over most of their attention. So expected to extend, if they do extend it or when they extend it, this is the next sort of generation of how that's going to be expanding. And it's worth thinking about how non-provider telehealth, remote monitoring, things like that, could factor into your overall strategy. It's not going to replace virtual visits with a doctor, but it might. Real quick, because I just happen to see the question and it's actually really pertinent for right now, so I'll answer it right now, even though I'm not supposed to. You can bill remote patient monitoring the same time as the APCM codes, but CCM is considered bundled in this, so you can't bill CCM and APCM at the same time. So this replaces care management except for remote patient monitoring, which is separate, and you can bill at the same time. Expect Medicare to adjust this over time. It's one of those brand new services that there's always outliers that they adjust for. So if you are doing this, it's worth having either a partner who's going to pay attention for you or pay attention, right? Come November when the final rule is released. They are super bullish on this. It's not going away, but in the margins, they might change things a little bit. What you can build with it, what you can't, things like that. So, greater scrutiny on telemedicine. As you might imagine, during COVID, they had bigger fish to fry. And now they have more ability. One, they finally stepped back and started seeing the amount of sort of increase in this. And two, now there's just more focus on, right, sort of making sure these programs are run efficiently in general. I won't comment on the methods that are being used, but even separate from sort of Doge, right, and that side of things, during the last, bit of Biden, it was also very clear that like audits are coming. They, more of a structured process maybe, but audits are coming as well. So none of the telehealth programs are particularly hard to stay compliant in, is the truth. And there's been a super clear voice from Medicare that they want these services, they see value in them, they think that they save money over time with the patient instead of costing more money. But if you're in the outlier skirts of this, doing bad faith like billing, because if you just think about it really quick, if you step back, it is much easier to be fraudulent with telemedicine than it is in person, right? If it's in person, you can only see so many patients. You have people there. You can look into it quicker and see. You can call the patient and say, "Were you at this place?" Telemedicine allows for just more difficulty sort of zooming in, and bad actors have taken some advantage of that. That's included with remote patient monitoring. It's included with some of the provider visits, although I don't think they're auditing those as much. But CCM as well, they're starting to look into. So anyway, the idea here is you gotta prioritize compliance. There's a lot of folks who started doing these things during COVID. They never really stepped back and said like, well, or did we like build these programs the way that we're supposed to? And no one really paid attention, to be honest, because it was COVID and soon after COVID. Now's the time to you don't have to. It's not crazy hard, but it's worth looking at to make sure that you're not doing anything that's gonna that just have the eye of CMS or OIG look at you. Outside of the general increased focus on fraud and abuse, remote monitoring is being particularly looked at. So in December 2024, they announced more audits of remote patient monitoring services. This includes some CCM2 in a different, not this specific announcement, but we're seeing an increase in care management programs as well. And they're basically saying that there are bad actors on the out, not the primary part of these services, but if you have, it's very rarely the provider twirling their mustache and like knowingly being shady or bad faith these things. It comes into play most often when you're outsourcing an entire telehealth program, care management, remote patient monitoring, things like that. Just make sure your vendor's doing what they're supposed to do, I think is the big thing. And that they're keeping on top of things, and that, as the sort of the audits happen, you really just don't want to be in their view, is the truth, right? So if it's an insane amount of patients and it only takes a few patients to say, I never got a phone call, or I never got, I never got a blood pressure cuff. for them to start looking into things. And that's just not where you want to be, even if you pass, right? So things to keep in mind as you move forward with these programs. I will say that when they announced RPM as one of the primary focuses, they got a lot of pushback from the industry. They say, oh, RPM adoption increased dramatically from 2019 to 2022. Well, 2019 was like the first year that this was allowed, and there was a pandemic in there. So like, yeah, you would expect it to increase, right? It doesn't mean that that it's all bad faith, people doing this. That said, you also want to make sure that, that you're dotting your I's and crossing your T's. And there's lots of good information out there to checklists and things like that you can use to do that. Zooming into RPM, because I did mention that as a big part of this. So again, with the audits here, you got to make sure that you're compliant with different payer programs requirements. I will say, and we probably should have, and maybe we'll send out after this some more information on sort of non-CMS side of things. There are different requirements. Medicare requirements are set, pretty easy to sort of follow. Medicaid requirements are different per state. Over half the states now will cover most of these programs under Medicaid. That said, some of them have restrictions on the specific, like some will allow hypertension only, some don't have restrictions on the different conditions. Some have different restrictions for maternal monitoring, right? So for like preeclampsia monitoring, it's paid more than general hypertension monitoring. It's worth looking through your payer mix and just making sure that you're up with all the different requirements, because it's easy enough to build out the program for just Medicare, and suddenly you're billing for Oscar and they have something slightly different, or things like that. Coverage is there. It's in the periphery that the coverage changes usually, except for a few outliers who don't have coverage. Florida Blue being a big one, and a few others, but the vast majority at this point, or at least the majority, if not the vast majority, have some coverage for these for one, for telemedicine, and then two, for these remote monitoring programs. RPM particularly, CCM is more hit and miss. It's more seen as a Medicare program, but your mileage can vary there too. Big pitfalls for the RPM side. One is device alerts without data. So for RPM, you have to have 16 measurement days of data each period. A lot of folks were just billing without that. There were waivers during COVID on how many of those measurements you needed. Those waivers are long gone, and a lot of folks are still acting like they're not long gone, which is, again, why it's important for anything you're doing that was related to non-in-person care, just to look to make sure that you're not following old rules, because the rules have changed a lot over the last few years. And not just COVID versus after COVID, but COVID versus after COVID versus like weird extension versus final rule year to year. So worth looking into, just to make sure that you're on the up and up in the periphery. That said, they're pretty clear, and from what we've seen so far, they're not looking to go after good faith programs. As long as good faith includes meeting requirements, right? But the patient-centered remote care programs are generally, at this point, seen as being useful and helpful for the patient from the Medicare side. They're going after give every man, woman, and child in your practice a heart rate monitoring watch regardless of need, and bill for it, or don't count measurements. You can also count text messages as measurements and bill for that. Things like that, right? The good faith programs are still, one, valuable to the patient, two, relatively lucrative at scale if you build it out in your practice, and also is just kind of a movement towards the future that's important to consider. And I know providers hate when you say consumer demand going forward, but kinda, right? Having some of these services makes the patient more engaged, stickier in the practice or the system, and allows some between visit care, which is more and more important. We're finding or more and more expected, I guess. We're finding as we go forward, and these things become more prevalent. I buried the lead a little bit on this one, given that I've been talking about strategies for success, but we also have some enumerated strategies for success, I suppose. Monitor regulatory changes, right? Big part of this is just keeping on top of that. I want to reiterate, none of them are groundbreaking. I mean, sometimes the language in the actual rule takes a lawyer, but there's plenty of us wonks out there that are sort of like distilling it to a point where it's useful to have a vendor for these programs, either your televideo vendor, your EHR vendor, or your CCM RPM vendor that helps monitor these things. You could do it on your own. But just make sure you do it, I guess, is the takeaway here, right? The big things for these are big waivers, which is legislative action, so it's not exactly subtle or hidden. And then each year Medicare's new final rule, which usually drops in November, which is important to see and figure out. When I was an attorney, a lot of my consulting work was like December 15th, and they never read the rule. I know they read the rule and we're changing major workflows around, right? So comes out in November, worth putting something on the calendar for November 20th, right? And read some of the things and see if anything you're doing is implicated in the changes. Comply. I won't read number 2 again because I think I've been saying that this entire time. And I'm a lawyer, so obviously everything's a nail, but at the same time, program compliance is really important. Patient-friendly technology, right? So you want to make sure that you're using things that are reliable, but that are also easy to use. This is more focused on the televideo aspect of things. I will say that this somewhat goes into that whole Medicare's like finally sort of shrugging and being like, okay, guys, you can do audio only, but like only when you need to. Having like standardized televideo that defaults to televideo and falls back to audio only is important. I wouldn't just have like call this number and then just continue on that way. And then finally, think about scalability. So there's a couple parts of this that I think is important. One is you need, and I'm sure most of you on this call understand sort of how necessary these things are to be built into your normal workflow, right, that you already are doing. But also consider how to expand to other sort of remote service lines that aren't telemedicine doctor-patient talking over audio, video, or audio. They all work well together is the truth, right? And a lot of them are less I don't know, the adoption is lower. A lot of folks are still doing annual wellness visits in person with the provider. Well, you really can do them remotely with at least until the waiver is done, with a remote nurse, with just some oversight by the provider, right? Direct supervision. Care management and remote patient monitoring are great for in-between care with a provider, with a clinical staff, right? Clinical staff member that then feeds things in and makes these sort of telemedicine visits easier to do, or either more often or more specific to the thing, the primary complaint they want to talk about. Has less problems with tech support because now you get paid for helping the patient with getting tech support sort of set up is either part of be part of the care management program, things like that, where you can have people reaching out to the patient between the visits. Not like download this, join, but generally, they're worth looking into how they all factor together, I guess is really what I'm trying to say here. And the only way that these things will work is when they're scalable by the office and also scalable relatively easily by the patient. Ease of use. Best practices. The first, and hopefully I got this through a little bit, is there's a lot of different remote care services that are covered now, both by Medicare and other payers. It's worth thinking about how they fit together, and it's worth thinking about, one, just from a patient care perspective, obviously, but also from reimbursements are going down. These programs are seen as making patients healthier in the long run, so they're being paid well. They're incorporating them into your practice. It's just everyone has a different tolerance for changing the workflow around. But if your tolerance is there, it's worth looking into incorporating these. Also important to think when a patient also needs an in-person visit, right? It's one of the beauties of having telemedicine one of the things that the worry is Medicare stops covering telemedicine, and suddenly grandma, goes to one of the virtual only services for $60 or $50 or whatever it is when they need help instead of going to their provider, right? The beauty of it doing these, telemedicine outside of a physician group is you can be in person when you need to be in person, and there's value there, and you have one provider who's taking care of sort of the entire health of the primary care, at least of that person, right? Or specialty care, doesn't matter. But the conditions that they're there for, and your staff knows, and they have a relationship. So having in-person visits is just as important as having, at least in my opinion, as virtual visits. Or at the very least, it's one of the differentiators. Even when I was looking for a primary care physician recently, I wanted them to be able to do telehealth with me, but also I would, if I just go to Amazon Care, if I just want telehealth, like I also want that relationship, right? And that's important. Prepare patients, right? So pre-visit calls, things like that. The professional care experience, I mean, this kind of is a given, but you'd be surprised how many folks aren't like thinking about doing these interactions a very similar clinical way as they would do an in-person visit. So that's always important. You can also utilize the technology pretty easily in these visits in a way that can be efficiency increasing. AI scribes, things like that make a lot of sense in these scenarios. And then finally, set expectations, right? So one, you have patient education materials go out for care management, things like that, but also just setting patient expectations. One, for follow-up. Two, for copay deductible. It's worth talking about that sort of thing, right? Setting expectations. Medicare has tried to get rid of the copay for care management services for 10 years now. And they say every time that we can't, because it's codified in the law that we can't waive copays for anything except for preventative services, and care management and remote care is not that. There have been umpteen bills that have attempted to get passed that gets rid of that copay, because generally the general consensus is these things are worth doing without a copay. That said, until that happens, it's not copay, it's coinsurance, right? The coinsurance, the normal 20% coinsurance that Medicare patients have to pay. So making sure that's upfront. 50% or so of Medicare patients don't have that because it's covered by a supplemental or they're joint enrolled, but a lot of them do. So make sure that you know who does, or at least you have a good idea who does, and that is a set expectation. I know I went a little over, so I'm going to go through this really quickly, but I think it's important. So we'll go to QA relatively quick, but just to sort of talk through this. There's a lot of momentum towards permanent change. Dr. Oz particularly has been a proponent of telehealth to the point where he was on the board of a remote patient monitoring company and has invested in a bunch of sort of telehealth companies. There is a lot of push right now to, one, extend the telehealth waiver and then also expand it, right? Given the current situation that we're in politically, for a major appointee to be like, there's no opponents to this is telling. And he's right. There's no opponents to this. There's differences of opinion in the margins, but no one says that you should go back to having to have, the patient come in every single time for everything. So I think there's a good chance, unless the non-telehealth sort of craziness covers this up, that something's gonna be done here, which is good. Also, the AMA has been looking and so one expansion is already in place, but they've looked at expanding, particularly remote monitoring, for 2026. Basically seeing that some of the requirements on these codes which they put in place to restrict sort of how often you could do these things or how many measurements have to be done for them to be billable. They've sort of seen that there's plenty of useful, like if you're in a weight loss program right now, you are required to weigh yourself 16 days a month for it to be a billable service. You could probably do it 3 times and there's no difference in clinical outcome. It's meaningful for you're on Ozempic for your weight to go to the provider, but it's probably not meaningful for you to sit there staring at the scale not changing for days and days on end. That might be very different for heart failure, where you're looking for fluid retention and you do want them to weigh themselves almost every day. But again, not one size fits all. So they're expanding the codes to say, okay, we're not going to have these requirements necessarily in here restrictively. And that is continuing to be done going forward. I mean, when they released these codes in 2018, 2019, there's been nothing but a sort of an expansion of the coverage, which goes to show that even though there's some bad actors that there's trying to crack down on, generally they just keep expanding coverage year to year. There's been almost no retraction. There's value in these things, and they see it, and it's not going away. Is the truth. And there's a bit of a, just in our business, we've been seeing more providers. I don't even know if this is a good thing, so don't take this as like a good or bad thing, who kind of feel like other providers might be eating their lunch by providing some of these services in the practice, and sort of a keeping up with the Joneses thing. I think that that might progress further, especially if Congress gets its act together and starts being, the uncertainty is one of the reasons that adoption is lower with some of these things. But yeah, that last part was obviously my opinion versus anything else, but take it how you will. I'm supposed to throw it to Carl, and maybe I will really, really briefly, but I do want to get to Q&A and not have sort of the full pitch, but a bit about us and sort of where we're from and what we do.
Just super quick, because this slide deck will be available for everybody, and certainly you can hit our website if you have other questions. But just Provounce is a full service company in the sense that we're headquartered in Indianapolis. We have our own warehouse with our own devices attached to our headquarters. So for people that want to get involved in RPM, we can drop ship devices right to patients' homes, to practices, to a hybrid. If you have big programs, we can be involved in refurbishment and logistics and branding. A lot of our clients want our platform to be able to document and have the bills created with the appropriate CPT codes and all the compliant documentation. Others that don't have the bandwidth want to be able to tap into our care management team, which are nurses, social workers, MAs, that can be an extension of your practice. And then at any time, 6 months, 12 months down the road, a lot of people will want to pull the programs back in-house after they're cash flow positive. So a lot of information that we could provide about RPM, CCM, APCM, devices and all that. So certainly there'll be ways to get a hold of us, but we really appreciate everyone's attention to Dan's information here, and he's going to answer a few questions now.
Amazing. Thank you both so much, Carl and Dan. Happy to read out a few questions that came in during the program. Our first question here is, do you need a special software platform to document APCM interactions like you would CCM?
So you don't. So I guess actually the answer, if you say like you do CCM, it's the same. So if you technically don't even need one for CCM, right, is the truth. But it behooves you to have one unless it's sort of built out in your EMR, which a couple EMRs do an okay job of that. Most just don't, to be honest. That said, you don't necessarily need to have a special software platform for APCM or CCM. I'm biased, given that I am literally in the APCM software platform business. That said, it is, if you don't want to do all the manual work and management and monitoring that goes around these programs to make sure that you are staying sort of copacetic, and you want to make it easy to bill and track that billing, it's worth looking into a platform. We're also seeing a lot of folks who, even though there's no time requirement of these codes, are looking to outsource APCM, just because even though you don't need to spend time necessarily with a patient every month, it can't be, I never spend any time on the patient, right? It has to be available. The one thing that'll get you in trouble is if a patient, has at some point interviewed and says, well, I tried to call them about my, my gout, and that was part of my care plan, but then they, they wouldn't talk to me without a visit. Not good, right? You have to be, it has to be available. So I again, biased, think it's worthwhile to at least look into a platform and see what it does, and that maybe you can make a decision. But given sort of the attention to compliance right now, I would recommend one. No EMR. Some EMRs do CCM well. It's too early for any of the EMRs to do APCM well, is the truth. They might get there. It took them like 9 to 10 years with CCM, sort of for the like two that I have in my head to get to a good place. But I'm sure over time it'll be something that is either built out with sort of like marketplace things or built out somewhat within the EMR or some of the EMRs. But at scale is really where the software platforms kick in. If you're trying to do this on onesie, twosie patients, you could probably do it on paper or in your EMR. If you're trying to do a program where it's you're hundreds of patients, the savings you get in time using a platform add up to be worthwhile, at least in my opinion.
And Dan,
Great. Thank you.
to that degree, if you're doing RPM and CCM or RPM and APCM, having everything pull into one place is hugely efficient.
Perfect, Carl. I think you just touched on another question, so I'm going to try to move on to the last few here. Does APCM apply to the patient's Medicare deductible or coinsurance?
Medicare when they released APCM, they almost like they basically were sad sounding in the thing that they had to charge a deductible, the coinsurance. So it is the 20% coinsurance applies. I will say that as long as you set expectations in front, generally 50% of patients or so have that covered, right? So knowing that ahead of time, who those are is usually a very useful thing. But otherwise it does. It goes towards, there's a coinsurance, 20% of the amount, and that goes towards the deductible for the year for CCM and APCM.
Right, and from the same attendee here, do you have any advice to physicians who continually get CCM claims denied due to another physician also billing it? I thought CCM was geared more towards primary care providers and not specialists who we see repeatedly also bill CCM.
Yeah, it's interesting because initially the idea was CCM primary care and then PCM, which is a worse paid, but also very similar service with one condition, specialty care. What we ended up finding, or at least we found, and the reason that Medicare sort of expanded it out is especially with cardiology and some of these, more chronic condition specialties, they kind of become that, like even if they have a primary care doctor, they're, cardiologists, still internists, and they're doing a lot with them anyway, if not all of the care, right? But a large part of it. So CCM in those scenarios will go towards, there's lots of cardiologists doing CCM, is the truth. The APCM is slightly different because APCM, there's only one per patient. You don't have to be a internal medicine or family medicine or primary care doctor, but you have to basically certify that I am acting in that capacity. Yes, I'm a rheumatologist, but when they have a sore throat, they come to me. I'm their primary care. Originally they were just going to say, nope, you can only be these specialties. They expanded it out, but said, no, but only when you're acting as primary care. So that's going to be way less common that is billed by specialty, right, providers. Most of our customers, so to answer the original question, what do you do when CCM's getting denied? One thing I always make sure is when you're enrolling in CCM, one of the questions you ask the patient is, are you getting, is this a service that you're getting elsewhere? Because there's no automated way on the CCM side to see if CCM has been billed for recently. So that helps a little bit, not all. The second thing is if you're getting denied for CCM, often the same requirements allow the patient to be billed for PCM, which you could do if you want to. But now, if you're primary care, we have a lot of groups that are saying, we're going to do APCM. We're going to do APCM, and if a specialist wants to do a CCM, Godspeed, but we're going to do APCM with our patient population. And that allows us, one, more flexibility, right? Because now you can do it without having to count time. But two, it is fully separate now, right? From any of the care. It's technically care management code, but you can bill it, other providers won't be interfered with you billing for APCM. Hopefully that was helpful. Yeah, you always have a few, but usually you can get it down to a few percent, unless you know that one of the specialties you referred to is doing CCM, in which case, we've had coordination between that before, where you can ask them to tell you when it's happening, or things like that. Move the referrals around.
Excellent. Well, I know we are down a little bit over time here, so I want to be respectful of everyone's time. But thank you so much, Daniel and Carl. And thank you, everyone, for attending. Please keep an eye on your emails for that post survey, as well as a copy of today's presentation. Thank you all. Have a great rest of your day.
Thank you so much,
Thank
everyone.
you.